Hello, my name is Kimberly Garza, and I am a DNP student. And today I will be presenting my DNP project, Implementation of the AHRQ Scheduled Rounding Checklist to Reduce Falls in a Skilled Rehab Facility, a Quality Improvement Project. My committee members are Chair Dr. Rachel Davis. My second reader is Dr. Lisa Stewart. Community member is Dr. Rosalind Blake. A little bit of background for my DNP project. Patients in a skilled rehab facility can be particularly vulnerable to falls due to complex medical issues, cognitive impairment, and environmental factors. And fall prevention strategies could significantly help reduce falls. Falls in the skilled rehab facility can contribute to things such as severe injuries, such as fractures, head trauma, which may lead to an extended length of stay in the facility or rehospitalization. These outcomes can result in substantial burden for both patients and the healthcare system. Patients in the rehab facility must rely on staff to assist with daily activities and adjust to changes in environment from their home setting, which can further increase their risk for falls. Falls can have a significant psychological impact on patients too, which can reduce mobility and the recovery time. Therefore, having some form of regular fall prevention strategies in place would help ensure that these patients are safe in their environment. To address these issues, implementing the evidence-based AHRQ scheduled rounding checklist offers a structured approach to improve falls in a skilled rehab facility. The benefits of using the scheduled rounding checklist consistently, it can reduce the incidence of falls and definitely improve patient outcomes. So the purpose of this scholarly DNP project was to improve patient outcomes by reducing the incidence of falls in a skilled rehab facility for high-risk patients. By implementing the AHRQ scheduled rounding checklist, an evidence-based tool to improve falls prevention, and the secondary aim was to include evaluating pre and post falls and fall-related hospital readmission rates by comparing pre and post implementation data. The scheduled rounding checklist, the evidence-based tool, ensures consistent proactive care to enhance patient safety. The implementation of the scheduled rounding checklist improves staff communication. It also helps with the comprehension of fall prevention strategies. It promotes accountability for staff and also helps them to address safety measures. Including clinical staff in fall prevention, it also reinforces the importance of fall prevention and shared responsibility in patient care. Consistent use of the checklist has shown to reduce falls. So, what is the significance of surveillance for fall prevention and nursing practice? Well, nurses play a crucial role in providing direct patient care at the bedside by assessment and surveillance skills. Nurses provide education to patients and their families at the bedside to ensure safety measures are understood and applied. And according to Ojo and Thimewong in 2022, they found that nurses play a significant role in fall prevention programs and have a considerable influence on their effectiveness and positive outcomes. Nurse-led fall prevention is supported by empirical evidence and backed by evidence tools such as the scheduled rounding checklist, which can reduce falls and improve patient outcomes. So based on my integrated review of literature, I found some 3 different main themes. One was intentional rounding tools, and according to DeMasi and 2022, Grial in 2019, and Jenko 2019, and Oko Odoi in 2023, they found that an evidence-based rounding tool during rounds leads to proactive patient outcomes, decreased patient falls, and increases patient satisfaction and is perceived by staff as helpful. Also, Damasi in 2022 and Jenko in 2019 found that some tools provide staff with clear expectations regarding patient safety checks. Morgan, in a 2016 study, used a tool which included the 4 Ps, which is potty, position, possessions, and pain. Some other tools from studies were broader and would address any need. Rounding tools were found to be used every hour, every 1 to 2 hours, or even 2 to 3 times a week. And these tools were used by nursing leaders, nursing staff, students, certified medical assistants. And what they found was utilizing an evidence-based rounding tool has been shown to reduce patients' falls, leading to positive changes, according to Grillo in his study from 2019. And an evidence-based tool increases patients' quality of care, safety, and satisfaction, according to Jenko's study in 2019. The most efficient and effective tool available for fall prevention is one that incorporates a fall prevention checklist and ensures the implementation of universal fall precautions. And based on the literature, the AHRQ scheduled rounding checklist is exemplary in this regards. The AHRQ scheduled rounding checklist, it includes those 4 Ps and ensures universal fall precautions are in place. The study by Damasi and Jenko, they utilized the 4 Ps and they found that the 4 Ps positively impacts the safety of vulnerable patients, helps to reduce fall rates, and leads to a shorter length of patient stay by minimizing complications and improves patient and staff satisfaction. The second theme that I found when doing the literature review was communication. And based on Basic and Gleiner study in 2021, they found that a rounding checklist can improve bedside communication between patients and staff, which has shown to decrease the incidence of falls because patients' needs are communicated and provides an opportunity for staff to go through fall risk and prevention strategies. And they found that with the increase in patient staff communication about fall risk and fall prevention at the bedside during rounds correlates with fewer falls. And communication among patients, nurses, and interdisciplinary staff improves with rounds as little as 2 times per week for up to 3 to 5 minutes at a time when you're making those rounds. So for my final theme that I found was about patient and staff perception. According to a study by Ram in 2019 and Roberts in 2020, they found that patients' perception of scheduled rounding is seen as a positive experience due to increased staff-patient communication, improved patient-staff safety outcomes, and even more responsiveness from staff to patient needs. They also found in that study that patients' environment and personal needs such as pain, patient safety, toileting, positioning, and personal items in reach were met. Nursing staff viewed rounding as an effective way to decrease falls and fall-related injuries and our best practice intervention to ensure patient safety and satisfaction are met. The theoretical framework that I used for this DNP project was the Plan, Do, Study, Act, the PDSA cycle. And this is a structured framework to facilitate continuous quality improvement in new or existing organizational processes. The Plan, Do, Study, and Act guided the DNP project. It provided a structured, iterative method for testing and implementing changes in fall prevention. And how it guided the project? Well, based on the plan, it identified risk in the skilled rehab facility and developed a strategy using the AHRQ scheduled rounding checklist. For the Do, it implemented the checklist on a small scale and collected fall data. For the Study, analyze pre and post intervention fall rates to assess the impact of this implementation. And then for ACT, it evaluated the results to determine whether to adopt or modify or abandon the intervention. And the impact on project formation, this theoretical framework ensured a systematic approach to quality improvement. It encouraged real-time feedback with team involvement, and it allowed for flexibility in adapting the intervention based on the outcomes. And it supported continuous learning and refinement of fall prevention strategies. The design for this project, this was a retrospective quality improvement project conducted at a skilled rehab facility in Southwest Texas. And the purpose was to evaluate the impact of the AHRQ scheduled rounding checklist, an evidence-based tool, and whether or not it would decrease fall rates and falls related to rehospitalization. The rationale for my D&P project, the one-time fall risk evaluation at the facility, at the skilled nursing facility, they only did a one-time fall risk evaluation upon admission on patients to the skilled rehab facility. And this did not adequately assess high-risk patients with comorbidities such as surgery, cardiac issues, or cognitive impairment. The method for my project was implementing the scheduled rounding checklist for high-risk patients with additional comorbidities, then collected retrospective fall rate data from the facility's electronic medical record 4 weeks before the implementation and 4 weeks after the implementation. The checklist was selected for the practical application in a real-world setting. It enabled comparisons of outcomes before and after the intervention and addressed the effectiveness of the scheduled rounding checklist, an evidence-based tool developed by AHRQ in reducing patient falls and rehospitalization. My sample for this project was the population was post hospitalized adult patients. They could not be from coming into the facility from home or from another facility. They had to be coming from the actual hospital. And they had to be adult patients over 50 years of age who had been discharged from the hospital and admitted to the skilled rehab facility within 24 hours of admission with comorbidities that have undergone surgery, have cognitive impairment, or have cardiac issues. The sample size of 136 charts were reviewed, 68 pre-intervention and 68 post-intervention from the facility's electronic medical record. There was no relationship between the researcher and the patients whose records were reviewed for data. And the inclusion criteria included age 50 years or older. They could be male or female, all genders included, admitted with 24 hours of hospital discharge to the skilled rehab facility, comorbidities, undergone surgery, have cognitive impairment, or have cardiac issues. And the data source was from retrospective electronic medical record review, 4 weeks pre and post intervention. There was no direct patient contact, and there was also facility approval was obtained prior to implementing the project. So for data analysis, the instrument was a fall data collection tool. It was developed based on literature review, and the categories for this fall data collection tool was falls related to hospital readmission, if they had surgery, cognitive impairment, or cardiac issues. The responses were nominal data of yes or no, and the data sources was from the facility's electronic medical record, and 68 records were reviewed pre-intervention and 68 post-intervention, with a total of 136 charts that were reviewed. The analysis plan, data was entered into a Microsoft Excel for statistical analysis. Nominal data was compared across pre and post intervention phases, and statistical test, which was the Z test for proportions, was selected due to the sample size and categorical data. The Z-test is appropriate for comparing proportions of falls and readmissions before and after the intervention. The Z-test identifies if there's been a significant differences in fall outcomes and following checklist implementation. Also ensures validity and reliability in quantitative analysis. So these are the results that came up whenever I finished analyzing my data. And as you can see, for fall prevention intervention, there were 8 falls. And then after implementing the intervention, there ended up being a slight increase in falls to 9. Also, when looking at readmissions to the hospital due to falls prior to the implementation, there was only 1. And then afterwards, after the implementation, it increased slightly to 2. So some of the limitations for the project, there definitely were, several limitations that were identified. For example, there was a short implementation period. This may have limited the time to observe long-term trends and fall rates because the limited time was due to the academic timeline of the DNP project. Also, the second limitation, there was staff turnover and a policy change during the project implementation, which may have disrupted adherence to the checklist. Even though there were reminder flyers that were strategically placed in staff areas, the passive visual prompts were reinforcements for clinical staff to adhere to the checklist, but it may not necessarily have been enough instruction for new staff that came on, or if there was staff that was there that was just peer in as needed. The sample size and project implementation in the skilled rehab facility, in a single skilled rehab facility, can limit the generalizability of the findings. And according to Pollitt and Beck in 2021, a reduction in statistical power and an increase in the risk of chance rather than true effects are associated with a smaller sample size. So increasing the sample size was not possible due to the limited number of eligible patients within the project timeframe. So for my discussion, the AHRQ scheduled rounding checklist, it did demonstrate feasibility in a skilled rehab facility. The facility leadership and staff showed engagement. Statistically, the project did not reduce falls or fall-related hospitalization. There was a slight increase in both outcomes, possibly due to staff turnover, a short implementation period, and a facility policy change. That facility policy change included that any patient that had fallen, regardless of whether there was an injury or not, if they were on an anticoagulant, they had to go back into the hospital, whether or not they were evaluated by a provider or not. However, even though we did have some of these limitations, the DNP project did broaden the use of evidence-based checklists to high-risk patients in a skilled rehab setting, because generally this type of tool was used in a hospital setting and also in the ICU setting in hospitals. So using this type of tool in the rehab setting, there's not a lot of research on that. The checklist reinforced proactive strategies for clinical staff to engage in fall prevention with leadership support. And based on these results, a longer implementation timeframe would be beneficial with consistent structured staff education on the checklist. Some implications for practice and future research. The checklist is feasible and shifted the facility's one-time fall risk evaluation to an ongoing structured rounding checklist and showed staff how to integrate the checklist into their daily workflow. The AHRQ scheduled rounding checklist consistently can ensure proactive fall preventions and strategies and increase staff accountability and can standardize routine safety checks. From a healthcare policy standpoint, the Quality Improvement Project is a proactive approach to improve falls and falls with rehospitalization. The checklist improves patient safety, satisfaction, and trust in clinical care. The checklist improved on current fall. It can improve on the current fall policy, and it can even be integrated into the facility-wide fall policy for the future. For further future policy, there needs to be a longer implementation period if this is going to be conducted. And integration of the checklist into the electronic medical record for standardization of documentation and structured staff training needs to be incorporated. The DNP project showed how an evidence-based rounding checklist reduces falls, improves safety, and guides the facility fall policy. In summary, the DNP project implemented the evidence-based AHRQ scheduled rounding checklist in a skilled rehab facility on high-risk patients. It looked at retrospective fall data, and it was evaluated pre and post implementation using the facility's electronic medical record. And the impact of this DNP project, it shows that the checklist was feasible in a skilled rehab setting and was a proactive approach to improve safety for vulnerable patients. To be sustainable, the implementation period needs to be longer than 4 weeks to incorporate into daily practice and for reinforcement of the checklist. Also, there needs to be consistent staff education to account for staff turnover and reinforcement and leadership support for continued success. Personally, the DNP project significantly enhanced my growth as a clinical leader. The project allowed me the opportunity to apply evidence-based practice into a real-world setting. By leading a quality improvement initiative, I was able to be a change agent for patient safety and fall prevention. I did encounter challenges when implementing the DNP project, but I was able to navigate those challenges and deepen my understanding of system level dynamics and how that all worked. Overall, the project equipped me with skills to improve patient safety outcomes on a broader scale, and I really enjoyed doing this DNP project. These are the different references that I used for my DNP project, and I would like to thank you so much for this opportunity for presenting my project. It was quite touching to be able to do something like this and to be able to explore the different avenues of how to initiate a quality improvement project. Thank you so much.